thank you for having me. My name is Virginie Lafage. I'm French, but I live in New York, and I'm running the research program for HSS, Hospital for Special Surgery. I've been in the US for 15 years. I'm really involved with ISAG, with the SRS, more on the deformity side than on the degenerative side. In our hospital, we have about like 15 spine surgeons, and our research group is about like 9 people, from med student, engineer, visitor, or a few people that are collecting data and enrolling patients. In my background, I'm a mechanical engineer by training, so I don't come from the medical field. I was very fortunate to do my training with Jean Dubousset when I was in Paris, engineering school, and he's the one who taught me about spine and pushed me to stay in this field.
Okay, thank you. You can share your picture, okay?
Okay.
All right.
Where's my PowerPoint? Let me see. There we go.
Yeah.
Okay, so I'm going to talk about adult spinal deformity and what we have done so far, and what is the next step from a research point of view, and also like to understand the disease a little bit more. So what do we know? What is really interesting with adult spinal deformity is that it's quite a complex pathology, because the spine can get deformed in any plane. You can have a coronal deformity, a sagittal one, an axial one, and it really affects like everything. We tend to look at the X-ray and measure the deformity on the X-ray, but at the end of the day, the pathology also affects the disc, the ligament, maybe also the central system. So it's not just a malalignment of the bone; it's a global problem. And it can come like from any source. So you can have a deformity because of degenerative disease. You can have some traumatic because of poor bone quality. You can have deformity that progress from the pediatric deformity and then stabilize and then become more severe with age. Or you can have iatrogenic one. That means deformity that appear after a surgery that was not so successful. And so you're all very familiar with a degenerative cascade, where you can first see some disc change and then the facet or the disc collapse. And, if you're lucky, the spine is going to stabilize and not create any trouble. If you're unlucky, maybe you're going to have some stenosis, some spondylolisthesis, and all that participate to the deformity. And so the reason why I'm mentioning like degenerative process is because it doesn't matter where the deformity comes from, whether it's a de novo deformity, a traumatic one, or anything, because with age, you're always going to have an added layer of degenerative change. And therefore, you're going to have, of course, the visual representation on the X-ray, but you're going to have some change also in the density of the bone. You're going to have some change in the muscle mass, muscle tone, and maybe the motion is going to be different. So this adds a layer of complexity when you come to this disease. So in addition to being complex from an imaging point of view, this is a pathology that really impacts the quality of life. So this is a study that we did with the ISAG and Chebes, where we use what we call like the SF36. So SF36 is a general survey to measure the quality of life and the physical function of the patient. And so what you have on this graph, and I don't know if you can see my, here on this graph, you're gonna have like the general population, then the general population, and in the red, adult spinal deformity. So you can see that those patients, they are much more disabled than the general population. But what is quite interesting is that their level of disability is as bad as patients with chronic conditions such as cancer, diabetes, or heart disease. So the adult spinal deformity patient, they present some disability and some lack of function. We also did a second study where this time we tried to compare like different morphotype. So this is a general study, so adult spinal deformity versus cancer or diabetes. Now if you take like patient with a lumbar curvature, so the classic lumbar degenerative scoliosis, look at that. Now the level of function is 35. So that means that they have like the same level of disability or even worse than patient with OA or heart disease. Now if you take a patient with a lumbar scoliosis and a sagittal malalignment, like a SVA greater than 5 centimeters here, the level of disability is the same than a patient with limited use of arm and leg. And now if you take a patient with a lumbar curve and a severe sagittal deformity with a SVA greater than 10 centimeters, there is no other disease in a book. So because there is some book that classify disease by disease the level of disability, there is no documentation of any other disease with this level of disability. That means that as soon as you have a deformity that is a 3D deformity with a lumbar scoliosis and a sagittal plane deformity, malalignment, it really impacts the quality of life. So we're not talking about a bad X-ray. We're talking about patients that cannot function anymore. And so there is always some debate about like, we need to take into account whether it's an IAS or a Denovo deformity. At the end of the day, what does matter? It matters if there's a loss of function. It matters if there is pain. It matters if there is disability. And it's very rare to see an adult patient. And when I say adult, we say like, 50-year-old, 60, 70-year-old to come because they're concerned about how they look. They come to see you because they're in pain, because they cannot function. They cannot carry their grandkid. They cannot go grocery. They come like to fix a problem, not to fix the way they look. And so when we think about defining a classification, because the disease is so complex that we like to classify so that we can talk about the same thing. We shouldn't do a classification that rely on X-ray. We should do a classification that relate on the problem. That means pain and disability. Because patients do not come because they have a bad X-ray. They come because they cannot function. And so that's what we try to do, like historically. When I say historically, like it started probably before my time. I've been in the US for 15 years. This work started like 20 years ago, where in the context of a study group, so the first one was a spinal deformity study group. Then this group disappeared and was replaced by the ISLG. The objective was to say, okay, everybody is looking at images. Everybody is looking at X-ray. It's okay. It's okay to do some measurement as long as there is some clinical relevance. Because why would you measure something that have no impact on the patient? It wouldn't make sense. And so that's what we try to do. We say, okay, we have all this radiographic measurement on one end. And then on the other end, what do we have? We have patientreported.com. So ODI, SRS, SF12, it doesn't matter which one you take, but you have some survey that the patient will fill, and those survey represent the level of disability, the level of pain. And so our first question was like, do the radiographic measurement matter? And if yes, which one? So we investigated if there was an association between X-ray and disability. And so we took, all the classic measurements, like the curb angle in the coronal plane, the pelvic inclination, the clavicle angle, everything that we learned from pediatric deformity. We took those parameters into account, but we also took into account the sagittal parameter. So the shape of the lumbar spine, the truncal inclination, and etc. And we just did a simple correlation to see which one do matter. And what we found is that the three most highly parameter in terms of correlation was the amount of lumbar lordosis versus pelvic incidence, the rotation of the pelvis, and the truncal inclination. So none of the coronal plane measurement really correlate with disability. So what does it mean? It means that, well, you can measure the curb angle, but it's not going to be representative of the level of disability or the level of pain. And that's how we define the classification, just based on the correlation between those parameters and the disability measured by ODI. So what's interesting with this classification is that it does look like a radiographic classification. If you just look at those parameters, you're like, well, this is just X-ray. But those parameters were chosen because they correlate with ODI. And even the transition from a grade 0 or grade plus, so no deformity to deformity, actually mean that you go from a low level of disability to a moderate level of disability to a high level of disability. So this work, as a group. And based on this classification, we apply that on our database that we developed with the ISSG and demonstrate that, well, overall, we have 1/3 of our patients with a double curve, 1/3 with a lumbar curve, and then, like most of the patients, they present some form of sagittal deformity. Not necessarily very bad, some of them are like just moderate. Maybe they have a small loss of lumbar lordosis. Maybe they have a little bit of truncal inclination, but compensate with a pelvic tilt. So this classification permits to categorize patients. And because it was designed based on clinical outcome, it means that when you improve one of those parameters, whether it's the rotation of the pelvis, the truncal inclination, or the lumbar lordosis, the result is that you're going to improve the quality of life of the patient. And this is based on MCID. So MCID represents like the minimum change that a patient can perceive. Because sometimes, you can have a statistical change, but it's so tiny that it has no impact on the patient. So MCID is something that the patient can perceive. And so if you look at the ODI here, if you change your pelvic tilt, if you change your SVA or change your PILL, then the patient will perceive an impact, a benefit. And the classification was designed for this purpose, but at least it's nice to have validation. And then a few years later, we're like, maybe something is missing. Maybe we need to take into account the age of the patient, because, okay, you can forget the kid, but would you treat the same way a 30-year-old and a 70-year-old? Or if you go in your street, we don't have the same posture, like whether you're a young adult or older adult, it's different. So maybe we should have different guidelines based on the age of the subject. And so we wanted to use the same approach that we use for the classification. That means that our first step was to look at ODI in the general population, not talking about adult deformity. And look at this graph. So if you look at this graph here, I'm going to try you can see the ODI increase. The ODI increase with age. And that's normal. It doesn't mean that you need a spine surgery. It means that when you're 80-year-old, you're not jumping up and down the same way that when you're 30-year-old. And so if this is our target, the ODI, to restore an alignment that permits to go back to an age-adjusted ODI, then maybe we need to revise our alignment target. And the alignment target to reach an ODI of, let's say, 30, 30 will be for 75-year-old, it's not the same that if you want to reach an ODI of 10. And so that's what we did with our next analysis, where we try to define alignment target so that the patient will reach their age-adjusted ODI. So again, if I want my 70-year-old to reach an ODI of 30, then it's okay to have a SVA of 5 centimeters. It's okay to have a PILL mismatch. Let me put my spotlight here. A PILL mismatch of let's say, if I'm 70-year-old, to have 10 to 15 degree of PILL mismatch, because I'm older. So I'm older, I don't need to reach the same level of ODI than a 20-year-old. So what does it mean? It means that with each decade, we can tolerate an increase of pelvic tilt by about 3 degrees, a loss of lordosis by 5 degrees, an increase of SVA by 2 centimeters. So if you have an older adult, so let's say here, you will have a PILL mismatch, SVA of 5 centimeters. If you have a young adult, then you want to match the lordosis to the pelvic incidence, and you want an SVA that is equal to 0 or even a little bit negative. Because again, like with age, we tend to increase the lordosis, increase the kyphosis, lose the lordosis, and maybe that's what we should restore on our patient. So now the question is like, okay, this is a lot of number. Does it really matter? Does it really matter, or is it just an academic exercise? And so we looked at that. So this is a busy slide, but what we looked at, in the old, even like 10 years ago, some people used to say, you can never put too much lordosis. So put as much lordosis as you can, it cannot hurt. And that's not totally true. So if you put a lot of lordosis, you're going to overcorrect your patient. If you overcorrect the patient, there is actually no clinical benefit. So you can either have the patient with deformity, you bring it back to age-adjusted alignment, and they improve the clinical outcome. If you go over that, there is no clinical benefit. It's not like the ODI is going to go even lower. There is no clinical benefit, but there is a risk. Look at this patient. So this patient developed a PJK. You can see here, like the fracture. But let me show you what would be the X-ray without the PJK. It will be this. So right away, you can see like, well, maybe the PJK appeared because there was an overcorrection. And therefore, the PJK is a way for the patient to go back to a position of comfort. Because look at this SVA. You cannot be like 60-year-old and have a SVA that is behind your sacrum. It's too much. And so what we learn is that when you overcorrect your patient, not only there is no clinical benefit, but there is a risk of PJK because, and this is, we don't know yet why, but the patients, they always try to go back to a position of comfort, to a position of, if you're on the older age, like maybe 5 centimeters in the front. And if the spine is fused, the only way for them to come back is by creating a PJK. And so this concept of age-adjusted alignment, more and more, it seems that it may help at mitigating the risk of mechanical complications such as PJK and PJF. And so, where do we stand now? Let me move this bar over. So if you look at like in 15, 20 years, collectively, like we start with a few patients, then we work together, like put like a 10 group together or 15 different sites together until we reach a few hundred patients. And we just collect like X-ray, clinical outcome, and complication. And based on those three simple tools, we were able like to develop a classification and then provide some guideline. Some guideline in terms of alignment, shape of the spine, risk of mechanical complication. And for that, we just use like simple stats. You know, it was nothing like, it was correlation and regression. So where do we want to go now? And some of this work already started like maybe a couple of years ago. I think there is like three areas where we need to go a little bit deeper. One will be like to understand the role of the lower limb, because we're not floating around, we're not in space, so our body rely on the pelvis, which rely on the lower limb. To understand the role of the 3D, then to look at muscle. Muscle are key, and then maybe to talk about a little bit about predictive analytics and all this buzz around like big data. So lower limb and 3D. So it's interesting, I was finishing my presentation today, and I received an email, an invitation from the SRS. So this is a webinar that is organized by Lenky. I think Lenky is going to talk, and I don't know who are the other speaker. And the title of the talk is like, "Don't forget the leg." So I was very pleased that the SRS is organizing this. I'm going to listen to that. I think it's like at the end of the month. But what is the role of the lower limb? And for that, to understand that, I rely a lot of what I learned from Dubussé. So what I did on this schematic representation, I put a sagittal deformity without compensation. So if you have no compensation, what do you think will happen? The trunk tilt forward and you will fall. So that means that you need a walker. So in order to be able to maintain our standing posture, we need to compensate. And there is two big ways to compensate. The first one is you just turn the pelvis backward. So the spine sits on the pelvis, you turn the pelvis, and the spine is vertical. That's pelvic retroversion. Or you can recruit the lower limb here and translate the pelvis backward. Let me show you two X-rays. Both patients have a sagittal deformity. The patient in the middle is rotating the pelvis backward. So he's doing this. And the patient on the right is translating the pelvis backward. And all that is possible thanks to the lower limb. So, and it's not more complicated than that. Usually it does become complicated when we put angle and make stuff more complicated than it needs. But if you are familiar with the work from Dubussé and his conus of economy, that's basically what the lower limb are doing. If there is no compensation, you're outside the conus, then you can rotate the pelvis, flex the knee, and that's it. That's the role of the lower limb. So why is it important? It becomes important when you have, because those patients usually the degenerative process does not stop at the level of the spine. You also include maybe the hip, maybe they have already a total hip replacement. And this means that any rotation in the pelvis will have an impact on the relation between at the level of the acetabular, and therefore you're all familiar with the hip spine syndrome that we see in a lot of those patients. This is another X-ray from Jean Dubussé that telling us to be careful when we look at X-ray, because when you're looking at an X-ray, what you see, you don't see the spine, you see a projection. So that's like looking at the shadow of this status. So what is the real 3D representation of the spine, and does it matter? So let me show you this X-ray, which is an adult with an history of IES. So you can of course see the double curve in the coronal plane. You can see the thoracolumbar kyphosis, and you can estimate the subluxation. So the question is what do we need to look at the subluxation, and does it really matters? And actually, like, it does matter. So Emmanuelle Ferrero, she's a French young spine surgeon in Paris. She looked at using EOS and doing 3D reconstruction, the clinical relevance of intervertebral rotation and subluxation. And what she found is that, well, subluxation is quite frequent in those older patients, and it does correlate with ODI. And again, this is common sense. As soon as you have a subluxation, the nerve roots are going to be trapped and pull on, and this generates some pain and disability. I'm going to go like very quickly about predictive analytics, but just like at a very high level. Predictive analytics is not a magic box. It's just a tool. It's just a tool that permits to develop some models that are more subject specific. Because when you do a classic statistical analysis, and let's say you use correlation or regression, what you do is that you describe the result of the group, but you cannot apply those results to one single patient. So for example, this is a slide from Ferrand-Pellicer that show, the SF36, so the physical component score of our patient. And it's interesting. So this is like the day of the surgery, and this is a follow-up. And if you look at it, it's just all over the place. The patient, you have a bunch of patients here, a bunch of patients here, and the blue line is the mean. And actually, in reality, only 5% of the patients are contained in the mean. The rest there is either above or below. So what does it mean? It means that we have to be careful when, let's say, when I publish a paper and give you the mean value of the group, it's only valid for the group. It's not valid for individual patient. And so that's what predictive analytics can do and help you. This means that predictive analytics can see the patient in a totally different way. So how do we see the patient as human? We visually see them. We know their demographic. We can look at the MRI, the X-ray, but the machine is going to categorize everything and find some relationship between all that. And so we play a little bit with it. And what we discover is that in our database of the database from Europe and from the US, we actually have 3 main types of patients. The first one will be like the young adult with a coronal deformity. The second group will be a primary deformity in the sagittal plane on the older side. And the third group will be a revision surgery. But if you ask me before doing this type of analysis, I would have tell you, like, I don't know, we have 20 types of patients. The reality is that, well, not really. The machine only finds 3 types of patients and 4 types of surgery. And so if you combine those type of patients with those type of surgery, now you can start to predict the clinical outcome and also the complication. And so why is it important? It is important because those type of model, if you have very good data, it can help you to anticipate the risk of major complication, of reoperation, of readmission. And if you take like 2 different patients, so here on the left, this is another slide from Dr. Pellicer. You have a 70-year-old, and on the right, a 20-year-old. So you can describe your patient, do some measurements, some demographic, some comorbidity, and tell the machine like what type of treatment you want to apply. And this will give you your risk of complication, your risk of reoperation, your clinical outcome. And this is only like feasible because you train the algorithm with good quality data. And then you can go even further, say like, I want to use this technique also to measure my image because I don't like to measure image. Nobody likes to measure X-ray. And you can use machine learning and AI to automatically measure the X-ray. And so at one point, we can put all that together and have some very valuable tool. So the question is like, is AI going to replace human? And the answer is like, absolutely no. This is just a tool. You know, if people try to tell you like it will solve all our problems, just don't believe them. It's just a tool that if you use it from a large high quality database, it can help you to identify like patient specific risk. So basically what the tool is doing is trying to reproduce a complex thinking process that you as a surgeon do when you see a patient. So that's a complement, that's not a replacement. And so the last aspect that I want to talk about is about like soft tissue. And I think like this is what really interests me right now. And it started like with actually that Jean Dubousset told me about that. Look at this slide here on the here. I'm gonna draw the vertebra. So the vertebra is this small blue dot. And now, if I draw the soft tissue, is all that. So the vertebra by itself is just a small component on our axial cut. And so we wanted like to try to understand the soft tissue and the muscle. And then we realized that we don't have any reference value. So we started a study a few years ago with a friend of mine in France on the young adult, like super young, 20-year-old, to try to understand, well, the fat infiltration, the muscle volume, because we didn't know exactly. And so what did we find? We found that overall, on those young adults, we have about 20% of fat infiltration. At the spine level, most of the fat infiltration is in the spine erector, about 28%. And overall, women have more fat than men. And this is even true in a 20-year-old subject. And so now we have some reference value. That means that we can keep that in mind and think about our patient. There is something that not a lot of people are talking about, will be like the role of the spinal erector, and more specifically the multifidus muscle. The multifidus muscle is quite interesting because this is a muscle that is going to stabilize the lumbar spine and maintain the lumbar lordosis. And if you look at this muscle, I have a graph here. In blue, you have the cross-sectional area of the multifidus muscle at L1, L3, and L5. And so what do we learn from the literature? We learn that when you have a degenerative disease, you have a loss of area, muscle area, mainly as a distal segment of the spine, of the lumbar spine, which is where you're supposed to have most of the lumbar lordosis. And so what does affect like this multifidus? You know, about everything. You can see that in patients with spinal stenosis. So they have 20% decrease of multifidus cross-sectional area. Same with patients with facet osteoarthritis. In the setting of adult spinal deformity, we know that patients with an anterior truncal inclination, so a positive SVA, have some imbalance between the flexor and the muscle extensor. Deformity, the severity of the deformity also correlate with the section of the multifidus muscle. Those patients with adult spinal deformity tend to have more fat infiltration. And so we look at that with Sam, like Emmanuel Ferrero. She did her PhD on this specific topic. And what she found is that as deformity increase, the fat infiltration increase. And so you can say like, okay, the fat infiltration increase because those patients, they're older. So it's normal with age, you have more fat in the muscle. Actually, that's not the only explanation, because she had three groups of subjects. She had a young adult volunteer, an older adult volunteer, and then adult spinal deformity. And what she found is that adult spinal deformity had more fat than the same age control group, which in turn have more fat than the young adult. So you have an added layer. You have age that contribute to the loss of muscle and the increase of fat infiltration. And then you have the adult spinal deformity disease that makes things like even worse. And so you can look at that on MRI or on CT scan. CT scan are actually pretty good because you can quantify the fat infiltration based on the voxel. And so what did we find? We found that as deformity increased, your fat infiltration also increased. So it's the story of the chicken and the egg. You don't know what comes first. But no, the question is like, is it a vicious circle? So you have deformity, you're not really active because you're in pain, because you're disabled. Then maybe you lose some of your muscle, which makes deformity even worse. We don't know. But that's an area where I think like we should do a little bit more investigation. Because why is it important? Why is that important? Because you're probably not going to treat the same way, or maybe one day we are not going to treat the same way a patient with like 50% of fat infiltration and no muscle versus a patient with good muscle. Because here you're going to rely everything on the instrumentation. So just to conclude this talk, I think like we've done a lot of work based on X-ray and clinical outcome. And now we need to go a little bit further. We need to go a little bit further, take into account like maybe the muscle, maybe the 3D, or probably like the function. So we're not going to do some gait analysis on everybody, but just some simple functional tests will probably bring a lot of value. Thank you.
Thank you, Virginie.
My pleasure.
Good presentation. Now we open the question for all people.
I think the knowledge is here. Collectively, we all develop the knowledge. So what is difficult is to make a simple tool, because to describe it will be complicated because we know what is like, let's say, kind of ideal, but then you need to take into account real life, because if I tell you like, okay, this patient need 15 degrees of more lordosis at L5S1. Okay. Sometimes it's possible to do it, sometimes it's not. And that's what I mean by real life. Maybe you're going to tell me like, well, but this patient has a solid fusion. I'm not going to break the fusion. It wouldn't make sense just to fit a theoretical model. And so all this knowledge is available, but we need to find a way to put it in a simple tool that take into account all those case scenarios. That means that I don't believe that we can have a model that tell you what to do. It doesn't make sense. But we can have a model that take into account what a few different scenarios for the patient based on you as a surgeon telling us this is not possible, or this technique, I'm not doing it, because at the end of the day also, I don't believe that there is one technique that is superior to the other one. It depends on the technique, the patient, and the surgeon. If you are very good with an anterior or lateral approach, it wouldn't make sense to tell you like do an osteotomy, or vice versa. Like Schwab, for example, is more a posterior approach guy. He doesn't do a lot of anterior or lateral. If I tell him like, oh, Frank, you need to change totally your technique, it's not going to work. is going to have a bad outcome, but not because of the technique, just because that's not the technique that he is good at. And so that's the difficulty of those models, in the sense that they should be patient-specific, but also surgeon-specific. And so to have a good model, we need to have access to also like your own data. And that's what we're trying to do, like with the SLG. So we develop, the calculator that I talk about in my slide, where I show like the two different patients. Those are customized for the type of patient that we're collecting, but also the different surgeons that are part of the group. So if you're a new surgeon, it's going to tell you like, well, the prediction based on other people outcome. But if you want something that is really relevant, then you need to share your data that is specialized to you.
Thank you.
Chico, do you have a question? Francisco, tá ouvindo?
Not so much.
Did I lost everybody in the presentation?
Can you hear it here, Virginia?
Yeah.
I'd like to ask you about the missed leaf. Do you think that you can, when you are performing in young persons, a missed leaf, to maintain the good sagittal alignment? MIS is a minimum invasive surgery using that leaf.
Yeah, so we are, it's difficult to talk about MIS because the technique evolved year after year. In the sense like what used to be called MIS like 5 years ago, now it's not called MIS anymore. So the problem of the use of MIS for sagittal alignment is that right now several of the technique, they work pretty well for the upper part of the lumbar lordosis. So L2, L3, L1, L2, but this is not where you need most of the lumbar lordosis. So that's a limitation of the current technique, which, by the way, like it's kind of like the same like for the osteotomy. Like we used to do osteotomy at L3 until we realized that it doesn't make sense. They should be like lower. But I think we will get there. We'll get there like with like the new technology, maybe the combined approach. But as of today, when we look at, because we have MIS data in our study group, there is a ceiling effect. So if you have a low to moderate sagittal deformity, you can correct the sagittal plane with MIS. If you have a severe one, then you're reaching the limit of the technique. And that's a little bit like the message that Uribe is telling like everybody, like, well, you can use MIS until the deformity is too severe. But this is only like if you want to correct the deformity, if you're only planning to do a decompression, that there is absolutely no problem. Like not everybody deserves a fusion. There is something like, we have to be like very clear about that. It's not because you have a sagittal plane deformity that you need a fusion. If you as a surgeon decide that the patient needs a fusion, then you need to correct it, because you cannot fuse someone in a bad position. You see a little bit like the nuance between the two?
Yes. Okay. Thank you so much.
Posso perguntar, Marco Aurélio?
Pode, claro.
Marcon de São Paulo, tudo bem? Hi, Virginie. It's Dr. Marcon from São Paulo. I'd like to ask you about we are seeing the rising of some new classifications using the Coronaplan that it's for a long time that we forget the Coronaplan for adult scoliosis.
Yep.
Do you think in the future, is it possible to use, for example, the EOS to produce a new classification for adult deformities?
I think so. I think like at one point, and the classification for the coronal plane, like from Dr. Q, is brilliant because it takes into account like the global coronal deformity versus like the apex of the curve. And so what has been done so far is like, you look at the coronal plane, you try to classify, you look at the sagittal, you try to classify, and you say like mine is better than yours. But you're absolutely right, we're talking about a 3D deformity. So maybe at one point when EOS will be available more broadly and the measurement will have to be like way easier, then we will have a 3D deformity because we did not even talk about the axial plane, So will it be like a radiographic classification? Would it be like maybe for a lot of those parameters, we don't necessarily need X-ray. Maybe it's just like a surface topography where you can also have the 3D, but at the end, yes, it's going to be like the 3D that take into account at least the coronal and sagittal plane, because just with the skin, you can see like the coronal malalignment, you can see the sagittal inclination, you can see like the retroversion. So maybe we need to go back to something that is more relevant because it's 3D, but also more pragmatic. Maybe we don't need like 20 different angles. I hope we don't. And just something simpler.
Thank you.
Alguma outra pergunta a mais? Bruno, do you have a question?
Olá. Deixa eu iniciar o vídeo aqui. Tudo bem? Meu nome é Lucas, eu sou de Santos, Santa Casa de Santos. Queria fazer uma pergunta. Hello, Virginia.
Hey.
Do you consider that the thoracolumbar burst fractures, they can lead to a significant change in sagittal balance, or the patients who develop in these changes more very attributed to degenerative changes in C, in changes?
So, I think like the thoracolumbar fracture or in general, the thoracolumbar kyphosis, it's a little bit like the coronal plane. We tend to ignore them, but they're extremely relevant. So yes, I think that they can develop, not only they can lead to sagittal deformity, but they are sagittal deformity because what will happen is that patient will compensate. We all compensate. That's if we have muscle and no neurological issue, that's the normal behavior. So if you have a thoracolumbar kyphosis because of the fracture that is not treated, what do? You're going to increase the lordosis below, and you're going to flatten the thoracic kyphosis above, which is okay, if you're young and muscular, until you're not. And that's like the aging process, unfortunately.
Okay.
So yes, they not only they can lead to sagittal deformity, but they are, in my mind, they are sagittal deformity.
Thank you.
Which again, like I'm not advocating for correction, but if correction there, if fusion there is, then they need to be corrected.
Thank you.
More questions? Virginie?
Yep.
I have a question, please. In spine, we have two important mismatches: a cervical mismatch and a pelvic mismatch. Okay. What do you think about the interrelation of the both mismatch? What is more important to do? No.
Yeah. So I started like really to love the cervical spine because I think it's extremely interesting. But it's also more challenging. So I don't think there is not a direct relationship between the two mismatch because they're too far one from each other. So it's more like step by step. So the way I like to think about the cervical spine is like there's two different constraints. On one, you have the horizontal gaze. So the patient, they need that to function. And then you have the foundation of the cervical spine, which is like the upper thoracic spine. So when the T1 tilts forward, then you develop a cervical lordosis. You know, very, 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 very simple. Then the question is like, why is the T1 forward? Maybe it's because you have an hyperkyphosis. Maybe it's because you have a big deformity. So there's a lot of explanation, a lot of reason why you will have like a steep T1. Maybe you have a PJK, and therefore the patient extends the neck. And so, you know, I like to think about the cervix. I don't like the term cervical lordosis because in the general asymptomatic population, you have 1/3, so 30% of the cervical spine that are kyphotic. So kyphosis is actually normal for 1/3 of the people. And so that's make it a little bit more challenging because we never think we were raised to think about kyphosis is bad, you know? And so those mismatch, they are like similar in terms of logic, but they address totally different need. And so when you see a beautiful cervical lordosis, I would say like, be careful. There's probably something going on below.
Okay, thank you. Have more questions? Alexandre?
No, it's okay.
Então, vamos acabar então?
Virginia, thank you very much for your time, for your speech. We all learn a lot, and we appreciate your time and your patience with us. Thank you.
Thank you very much for having me. It was a pleasure. And good luck with the COVID.
Yes, we will need.
Thank you again, Virginia.
Bye, everybody.
Bom, então podemos acabar e até segunda-feira que vem com mais uma. Obrigado a todo mundo, tá?
Obrigado.
Thank you.